The next presentation is by Dr. Michael Bianco from Maine Medical Center. Endovascular repair of delayed endologix AFX graft failure is superior to open repair with explant.
All right. Thank you for the opportunity to present. I have no disclosures. There are 3 generations of the AFX endovascular AAA system. AFX1 grafts made with strata fabric, AFX1 grafts made with DuraPly fabric, and AFX2, the current model made with DuraPly fabric and an improved delivery system. Despite improvements, reports of high reintervention rates and high rates of type 3 endologix have been published for all 3 generations of the AFX graft. This is demonstrated in these Kaplan-Meier curves by Ching et al. The primary treatment options for the delayed failure mode of the AFX device involve relining with a contemporary endograft or open graft explant. The purpose of our study was to evaluate the perioperative outcomes of endograft reline in comparison to open graft explant for the treatment of endologix AFX graft failures in our own single institution experience. The study sample consisted of 41 patients who had reinterventions on their previously placed AFX grafts. 28 of these reinterventions were EVAR relines, and 13 reinterventions were explants. AFX grafts were placed between the years 2013 and 2019, and all reinterventions were performed between the years 2015 and 2021. Data was obtained from electronic chart review. Primary composite endpoint was successful aneurysm exclusion without mortality at 30 days. Secondary endpoints were hospital length of stay and operative time. Demographics were comparable between the 2 cohorts. Of note, most reinterventions were performed 4 to 5 years after implantation, demonstrating the delayed failure mode present in the AFX graft. The indication for reintervention is stratified by endoleak with sac growth, endoleak only, sac growth only, or rupture was comparable between the 2 cohorts. Also, the distribution of reintervened upon AFX strata, AFX DuraPly, and AFX2 grafts was comparable between the 2 cohorts. There was no significant difference in the primary composite endpoint between the EVAR reline cohort and explant cohort, with relining performed with a 79% success rate and explant performed with a 77% success rate. Of the 6 reline failures, 2 went on to require graft explants, 1 required an additional reline, 1 became too frail for additional reinterventions, 1 is still undergoing additional reinterventions, and 1 was unable to be relined because of difficulty navigating the AFX stent struts. The type of graft used to reline and that specific graft success rate is displayed here. The graft of choice to reline in the earlier part of the study was AFX2 because this was the solution encouraged by the graft manufacturer. However, later relines were performed with bifurcated modular endografts with better success, although these more recent reinterventions have had less follow-up and thus we are less able to examine late sac growth for these relines at this time. EVAR relines were performed with shorter operative times than graft explants, and length of stay was significantly shorter for patients who underwent relines than for patients who underwent graft explant. There was, however, no significant difference in operative time between the patient's initial EVAR and patient's relining operation. Limitations of this study are its retrospective, single institution design, small sample size, and short-term follow-up. In conclusion, endograft reline produces analogous aneurysm exclusion rates when compared to graft explant and endologix AFX failures. Endograft reline reduces OR time, hospital length of stay, and mortality in comparison to graft explant. Additional follow-up is needed to demonstrate a long-term mortality benefit for graft reline. Thank you for your time, and I'm happy to answer any questions.
Great presentation. Open for discussion.
Hey, Nathan Lang from Pittsburgh. Whoa. Hey, Nathan Lang from Pittsburgh. Very nice talk, and I think we've all in the audience taken out a bunch of these. Do you have any anatomic characteristics of the patients that you treated? Could the ones who had been done endo, obviously been done open, but the ones that were done open, could they have been done endo, vice versa? Because that really limits, I think, a lot of the conclusions that you can draw from this if you can't match up the two cohorts anatomically.
So there were definitely more type 3 endolix in the reline group, but what I would say is that provider preference was the predominant reason for like whether reline was chosen or explant was chosen. We have some attendings who would basically just say that reline is off IFU. They've had their one chance at endovascular repair. It's time to, explant it. Whereas others are very much for reline because, you're treating a type 2 or type 3 endoleak that way.
Hi, Bernardo Mendes from the Mayo Clinic. Very nice presentation, and unfortunately, I think we all, if we are already not doing a lot of these, we will do a lot of these. But my question is very similar to Dr. Liang's question, which is, it's more of a suggestion. I think when you come with the manuscript to separate the types of endoleaks between type 3 and type 1, because I think it's a completely different animal. If you're doing an explant for a type 3 endoleak, that's one thing. If you're doing it for a type 1 endoleak, that means higher clamp and definitely more morbidity. And if you're doing a relining for a type 3 endoleak, that's a much simpler operation than that for a type 1 endoleak in which you're trying to increase the seal. So I would encourage you to make that data a little more granular because it's going to strengthen your paper quite a bit. But again, congratulations, very nice.
Yeah, thanks.
Hi, Ron Dahlman, Stanford. So this is a good opportunity just to remind everybody that FDA had a panel circulatory devices system panel review on November 2nd, which the SVS participated in along with VQI. And they just issued updated guidance on January 13th regarding the use of the AFX platform and recommendations for follow-up. So if anyone's not seen that or is not familiar with that, I would strongly recommend reviewing that. Thanks.
Thank you. Great job.
Thank you.